Now I'd like to introduce Dr. Brian Funaki, which is a professor of radiology, interventional radiologist at the University of Chicago, to talk on what's the best stent for SFA. Thanks for so much for coming, Brian.
Thanks.
You move forward here.
Whoa. All right, can we get the first slide up? Okay, first of all, let me go backward one. So I was tasked with, and first of all, thanks Marcelo and John, this is a tremendous meeting as usual, and I'd just like to thanks for the invitation. The topic of my talk is what's the best stent for the SFA, and is it lesion dependent? And I will also say, although I forgot to put the slide in, I have no disclosures. So I think anybody who treats the SFA realizes it's a challenging vascular territory, and for a variety of reasons. It elongates, it compresses, there's inflammatory responses, and so on and so forth that makes it a particularly difficult area to treat endovascularly, I think. And if we look back at some of the studies that have been done, and I'm going to primarily in this talk focus on the randomized blinded control, no, maybe not blinded, but randomized controlled studies that have been published in the literature. But if you look at the primary stenting, is it better than PTA was the first question we probably should ask. And if you looked at the randomized control studies done between 97 and 2003, none of them really showed substantial benefit. But none of these were done using nitinol stents, which I think most people now would agree appear to demonstrate superiority to some of the earlier stent designs. And then the other thing that's important to remember, that most of our best published current data that argue for stents really are based on short and intermediate benefit or restenosis, and really not sustained durable clinical benefit. So this is kind of the way I look at a lot of these studies, and as Dr. Brothers just showed, there's a whole different field of looking at the different metrics you can use to evaluate, what's better than something else. The way I think about it is, a lot of the early studies will look at restenosis, and then they'll go to primary patency, and then freedom from target lesion revascularization, and then clinical benefit, is it durable, and then finally, is the clinical benefit worth the cost? In terms of the SFA, I would argue we're probably about here. We're starting to see, I think, proven clinical benefit, and a lot of these earlier things that are established a few years back, but we're definitely getting there. Now, why are these metrics important? Because I think we need to speak the same language as our patients. And if you look at some of these things, you can see this was something I took out of the AARP magazine. They talk about avoiding stents. And this comic is sort of like, we need to be speaking the same language as our patients. So the randomized trials using nitinol stents in the SFA, there's 5. And if you look at these, I'm not going to go through all these sort of in detail, but just as a group, these first 3 all showed basically an advantage of stents versus PTA. The earlier ones looked at binary stenosis. This third one looked at target lesion revascularization at 1 year. Looking good. Then these last 2 were sort of relatively equivalent. And the one thing you should look at and take into consideration when we looked at the last one is that they treated relatively longer lesions, and those tend to be more difficult to treat with anything, but particularly bare metal stents. So if you look at what I think is a take-home points for bare metal stents, we know that probably nitinol is much better than PTA for short and intermediate length lesions. But they're really not much better than PTA, arguably, for longer lesions, and neither PTA or bare metal stents are very good for long lesions. There are 2 trials with covered stents, the Vibrant trial and the Viastar trial. In the Vibrant trial, which was the earlier one, they treated patients with longer lesions, bare metal versus stent graft, and found really no difference in primary patency at 3 years at about 25%, which is kind of so-so if you think about it. The newer trial, the Viastar trial, was 141 patients with longer lesions again, and then they used basically a newer model of stent graft that had a contoured edge. It was heparin bonded. It was a next generation stent graft. And then at 1 and 2 years, the primary patency was better than grafts. You can see 78 versus 53 and 63 versus 41, but there was really no difference in TLR or clinical outcomes. So something to sort of think about also. Again, you need to always consider the metrics when you're looking at these studies. But the take-home points would be, I think that most people would agree that the patency of covered stents is less affected by lesion length And the longer lesions are probably better treated by covered stents compared to bare metal stents if you're going to do endovascular. But the clinical benefit really hasn't been shown to date. All right, so that brings us to the drug-eluting stents in the SFA. Again, going to go through basically 4 trials in this one. The first 3 really failed to show any improvement, and that was sirolimus stents. And what most of these studies showed that basically early on these did well, and then there was rapid restenosis. Now the one thing that's changed that is the Zilver trial that just actually reported, I think at Viva a couple months ago, the 5-year data. I'm going to talk about that in just a second. But that one at 1 year was substantially better versus PTA, and the 5-year results now were recently released, and it's continued to show very good benefits. So I don't know if you're familiar with the way this study was done. It's sort of randomized, kind of interestingly. They treated randomized patients treated to PTA versus Zilver, and then the patients that failed primary PTA, they re-randomized again to bare metal and Zilver. So the initial group, the primary group at a primary patency at 5 years was better, and the provisional group was also better. If you looked at the freedom from target lesion revascularization, again, the primary group was better and the secondary group was better. And then finally, which I think is really important, they looked at a clinical benefit index, which was the freedom from persistent or worsening claudication, rest pain, ulceration, or tissue loss. And also, both the primary group, the Zilver PTX group of 80% versus the PTA bare metal stenting of 59%, and the provisional group 82% versus 64% was better. So I mean, this is the first study that I think shows really good benefit, good clinical benefit at 5 years and good durable benefit. And those benefits continue to increase at 5 years, it appears. So the take-home points for the drug-eluting stent trials are that while sirolimus seems to have a good early result, at least the trials to date have been sort of plagued by rapid restenosis, and that begs a lot of questions. You know, is it dose, delivery? Could you use a different drug? The paclitaxel-coated stents seem to be superior to the bare metal stents. The one caveat to that is in the Zilver trial, they were relatively short lesions and 1 stent was used, so you don't know if that's going to necessarily be extrapolated to longer lesions with more than 1 stent. Then I'm going to briefly go through 3 meta-analysis that have published to date, and these are all pre-Zilver 5-year data, which I just thought was interesting because you have basically 3 different groups looking at the same data, coming up with sort of 3 different interpretations of that. So if you look at JVS, their conclusion was the immediate technical success was better with covered stents, whereas paclitaxel-eluting stents and paclitaxel-coated balloons offer the best long-term results in the femoral popliteal artery. The European Journal of Vascular and Endovascular Surgery said performing PTA with optional bailout stenting for above-knee lesions is the preferred strategy in patients with intermittent claudication, but for chronic limb ischemia, more studies are needed for recommending an optimal treatment strategy. And then if you look at the Cochrane collaboration, they said although there was short-term gain in primary patency, there was no sustained benefit from primary stenting of lesions in the superficial femoral artery in addition to angioplasty, and future trials should focus on the quality of life for claudication and limb salvage for critical ischemia. So where does that bring us? These would be sort of my interpretation, and I think the conclusions we can take at the moment, which is 1, there's no universal consensus on stent versus PTA, but with that in mind, if you're going to choose, in terms of the best stent, I think that nitinol is clearly shown better results than stainless steel. In terms of the geometry of the stent, there's really no proven best at this point, and I think every generation of stents probably getting better. In terms of drug elution, the drug-eluting stents, the paclitaxel stents, are better than bare metal, and paclitaxel appears to be better, at least with the data to date, than sirolimus. In terms of lesions, bare metal stents are better than PTA in the intermediate length lesions. Those are task A and B. And stent grafts appear to be better than the bare metal stents in the longer lesions or occlusions of task C or D. And finally, sort of to simplify it even more, so the bare metal nitinol stents would be these types of lesions here, the type A and the type B lesions. And covered stents in the type C and the type D lesions. And that's it, thanks.